Dr. McKetta back to visit with us. Yay. Anyway, so for those of you who don't know, Sarah has been with us since 2014 is what she said, right? Has known us even before that, I think, and it's just a joy to have her back. One of our illustrious and super duper MD PhD students. So we have very few of those, sadly, and Sarah is one of them. And so we're very happy to have her back. She has spent time since at Harvard as a postdoctoral fellow, and I will go forward. And it's just a joy to have her back. Me personally, and I know many of you around the room know her. She is an epidemiology whose work focuses on identifying population health disparities and structural causes that perpetuate those disparities. Her research includes the topics of health, LGBTQ health, alcohol use, and chronic health conditions. She, of course, is trained here and has since gone on to do the PILE, interestingly, policy fellowship. And so this is a huge opportunity for the connection of epidemiology and policy, which she has done quite a bit at both Harvard Medical School and the Chan School of Public Health at Harvard. Welcome back, Sarah.
Charlie, it's so nice to see you. Thank you guys so much for coming. It's so nice to see everybody. Thank you for coming to my talk. I'm Sarah McKetta. I use she, her pronouns. I'm a postdoctoral fellow at Harvard Medical School in the Department of Population Medicine, as well as the T.H. Chan School of Public Health, the Department of Epidemiology. And I, again, want to thank you guys all so much for coming to hear my talk. It's entitled, When Life Gives You Lemons, Quantify Their Impact, Revealing Health Disparities to Inform Policy and Intervention. And I may or may not sit down at some point because I'm really pregnant. So I'm gonna have a chair handy. This should be about 45 minutes, maybe up to 50 minutes, and I'll leave some time at the end for questions. All right. So I'm opening with my mission statement. This is also how the talk is organized. I'm a trained social epidemiologist and physician scientist, and my work is centrally focused around novel measurement and using that to uncover hidden disparities that ultimately inform policy and interventions for population health. And to sort of situate you to the specifics of my scholarship, I wanted to dig into where I'm coming from and how I arrived at this program of research. So it's going to be kind of a slideshow of photos. I graduated from Harvard College in 2008 with a degree in biological anthropology. This had a large focus on women's health and sexual health. This picture was taken before we knew the economy was going to crash in 2008. Unfortunately, when it did crash, I had enough of a social safety net that I was able to move back home to Texas, which is where I'm from, and look for a job. And my job out of college, I ended up working for 2 years at Planned Parenthood. It's about a 20-minute drive from my childhood home in Austin. And it was here that the social determinants of health became extraordinarily apparent to me. The service population was very much women of color for whom English was a second language. They were underinsured. They often already had children at home. They usually had precarious employment. And even if they did have insurance, insurance wouldn't cover the services that we provided at our clinic. So they often had to make very difficult choices around cost of services. That was a major barrier. What this meant in practice was that people would often forego optional medication like sedation during abortion procedures, or they would delay care until later in the pregnancy because they couldn't afford it right now, and that would lead to more precarious situations medically. So this, for reasons that are probably very obvious, got me extremely passionate and interested in the social determinants of health. And I pursued master's training in public health back at Harvard to try to get a language and a lexicon and a toolkit to start building a career to address some of these social characteristics and how they determine population health. I continued to focus on women's health, but also became more interested in behavioral health more broadly. I think one of the things that I was beginning to understand is that sexual and reproductive health are extremely psychosocial, and they use a lot of the same processes that you expect to see in kind of other health behavioral health outcomes. And it was at this time that I started seriously considering a career in medicine. After my MPH, I went back to Planned Parenthood for 2 years. I was working at the Planned Parenthood in Boston. It's about like a 5-minute walk from Boston University. And this was a very different environment. It was here that it was extremely apparent to me that even though we were offering the same clinical services, being in a different policy environment made a material difference for our patients in a way that actually really did impact their care and the availability of what kind of services they could receive. So in Texas, it was against state law, as many of you know, for insurance to cover abortion services. Until the ACA was passed, insurance wouldn't even cover birth control. In Massachusetts, it was always a state law requirement that insurance companies covered abortion services, and the birth control was free and freely available. So our patients who were coming in for the same services got care immediately for free and earlier in the pregnancy. This won't surprise you, but the experience of seeing how these different laws and policies played out in otherwise identical clinical environments really did light a fire in me to start understanding the structural and sort of policy causes of population health. And I wanted to pursue more training so I could get a framework for both measuring them and ultimately, hopefully, dismantling them. So in order to do this, I came here. I pursued more graduate training. In 2014, I came to Columbia to pursue joint MD and PhD training in epidemiology. And at first I thought I might train to become a women's health provider. As I got deeper into both medical and epidemiologic training, it became clear to me that my real passion was in epidemiology. My clinical lens continued to be an extremely important component of my training, and it was informing disease pathophysiology, health systems, but it was epidemiology that allowed me to think at a more population health kind of structural level. And so my research interests continued to be on health disparities and the systems that perpetuate them. And I expanded my focus to include broader behavioral health outcomes like substance use, and also developed an expertise in measuring structural exposures. I got a lot of training in measurement here. And that was so that I could better understand what are the sort of levers that are actually driving health disparities that are operating upstream. I don't have any graduation photos because both graduations took place during COVID. So since graduating, I've been working as a postdoctoral fellow at Harvard, across the medical campus and the medical school, as well as in the T.H. Chan School of Public Health. My lab primarily focuses on LGBT disparities, which I'll talk a bit about in this talk. Most of the focus is on reproductive and perinatal disparities, although we also look at chronic processes of aging, which I'll also discuss. And I've continued advancing research related to novel measurement techniques, always with an aim to ultimately inform policy and intervention so that we can translate these findings into action. So that's where I'm coming from. That's how I arrived at this mission statement. And I'm going to walk you through some examples of my past, ongoing, and future scholarship that will kind of give you examples of this mission statement. I'll also highlight some methodological considerations that I've had to think about when doing this work and some barriers. And I'm going to organize this by topic. So I'm going to start with my work exposing health disparities. And for this research, I primarily focused on outcomes related to women's health, alcohol, and LGBT health, sometimes all three at once. So I'm going to start by discussing some of my doctoral work. This focused largely on social position and social roles and how those contributed to national trends in women's alcohol use. This work was motivated by findings that over the past couple of decades in the United States, the gender gap in alcohol use has started to close. So what that means is that women have been drinking more than ever. Let me see, can you see my mouse? No, yeah, okay. Yeah. Women have been drinking more than ever. This is the dashed line, but this dotted line men has been largely stable over time. And there was a lot of scapegoating in the media about one specific social group that might be driving these increases for women. This is specifically women who parent. So there was a lot of media concern about mommy drinking, which seemed like it was kind of a backlash against internet mommy blogging culture. So along with my brilliant PhD mentor, Dr. Carrie Keyes, I wrote a series of manuscripts where we dug into women's social roles and women's social position to shine a light on what was motivating these trends in gendered alcohol use. So we used very simple epidemiologic techniques. We basically leveraged national surveys to look at trends over time in binge drinking, but examine heterogeneity. So we first chose to look at heterogeneity across three different axes. So that's gender, this is red versus black. Age is the three panels here. And parenthood status, which is the dotted versus the solid line. Across all three age groups, you'll notice that women were increasing drinking, but they were at different rates depending on where they were in the life course. For a lot of behavioral health outcomes, including alcohol use, these behaviors wax and wane throughout the life course. This is a pretty known pattern, but so do social identities and social roles. I just want to draw your attention to this main panel in the middle. So our major takeaway from this paper was that women are drinking more than ever. The increases were most pronounced from women in the midlife. And they weren't differential by parenthood status. So even though women in the midlife were drinking more than ever, it wasn't because they were parents. These were parallel lines. So moms drinking more than ever couldn't be what was driving gender-based national trends. We decided to dig into the question of which social axes actually did matter for national trends. And we identified major heterogeneity in trends in binge drinking by socioeconomic position, where the increases were actually dose response as either income or education increased. This purple line here is the highest income group, followed by the blue line. And so this suggested to us that there is a social role that's motivating these increases, but it's not related to parenting. It might be related to something like labor force. In the next paper, we dug into the labor force angle. And here we looked at working men and working women in the midlife, and we used these identifiers of occupational prestige. And we found that the most pronounced increases in binge drinking were among women in the midlife in high prestige careers. So this is like lawyers, doctors, professors. That's the blue line here. Sorry. By drilling down into these social axes, we can start to think about who should be the target of screening efforts, as well as targets of intervention. So when we think about this translationally, we know that physicians rarely screen women, and they rarely screen people who are in the midlife and older ages. Most people who are screened for binge drinking are young men in their college age. And so knowing which women are increasing their binge drinking can also help us tailor both not only our intervention, but also our messaging. And the other thing to think about is that from a population health perspective, while this is the group that's increasing drinking the most, men are still drinking more than women. So we need to not lose sight of that. So in my postdoctoral work, I've continued advancing research related to gender trends in drinking. And I brought in information related to another key dimension of identity, and it's also a major social determinant of health, which is LGBT identity. Across the majority of health outcomes that have been examined over the past 3 decades, we see that LGBT folks evidence worse health. And this is particularly for alcohol and drug use. We see that sexual minority women have riskier use than heterosexual women. And in this work, which just came out, we found something very surprising. So the LGBT disparities in binge drinking are starting to close. And if you look at the red lines, these are LGBT folks. Blue lines are cisgender heterosexual folks. The solid lines are men and the dashed lines are women. If you look at this middle panel, this is people in the midlife. Men's rates of binge drinking are falling, regardless of whether or not they identify as LGBT. For LGBT women, rates are stable, but the disparity is closing relative to cisgender heterosexual women, and that's because cisgender heterosexual women are drinking more than ever. So it's striking that the disparities are closing, not because LGBT health is improving, but because cisgender heterosexual health is worsening in this one area. And of course, this has implications regarding who should we be targeting for prevention and intervention. So over the past couple of years at Harvard, the majority of my scholarship has been related to examining health disparities by sexual orientation and by gender identity. So over the next few slides, what I'd like to discuss is some highlights from that work, as well as some methodological considerations to doing this work. So we've known for decades that LGBT folks on average have worse health than their cisgender heterosexual peers, but there are barriers to examining these disparities. The first is that we're often dealing with very small n's. If you think about the previous slide, I basically had to lump all LGBT folks together in order to also look at age and gender trends. And that's not the experience of being LGBT. There's a lot of variety within those identities. And until 2014, most national surveys actually didn't even ask about LGBT identity. NIH didn't consider LGBT folks a health disparities population until 2016. And only in the past couple of years did they release a NOC calling for more LGBT research. So there's been some sort of structural barriers to doing this research. For sexual orientation in particular, most measures, even when they're asked about in national surveys, most measures do so in a way that's not consistent with what we would consider gold standard practices. So sexual orientation is a multidimensional construct. It encompasses identity as well as behaviors and attractions. And that requires asking questions about identity, behavior, and attraction. And I'm gonna walk through why this matters in a couple of slides. So the first example I wanna highlight, we address some but not all of these barriers. So again, because most national surveys didn't start asking about sexual orientation until 2014, examining outcomes longitudinally has been very challenging. So fortunately, the Nurses' Health Study, which is the data source I've been using for most of my postdoc, we've been following a group of female nurses for 35 years, and we asked about sexual orientation identity in 1995, which is a full 20 years before most national and CDC surveys started asking questions about sexual orientation identity. In this paper, which came out last month, we were able to examine disparities in all-cause mortality by sexual orientation. And these results were really staggering. These are just from the Kaplan-Meier curve. But LGBT women died 26% sooner than their heterosexual peers. And because we had sufficient information to disaggregate lesbian women from bisexual women, for the first time in any study in the United States, we were also able to demonstrate heterogeneity within subgroups of LGBT women. So lesbian women died 20% sooner than their heterosexual peers, but bisexual women died 37% sooner than their heterosexual peers. And these findings really highlight the need to measure and examine these different identities in distinct ways because they have different risk profiles. We can start to understand why these subgroups might be much more vulnerable than others, but only if we're able to really get enough information to show these differences. I also want to point out, it's okay, it's fine. I also want to point out, even though these results were robust to just every single sensitivity analysis we threw at them, we were working with very small numbers. So only about 1% of the sample actually identified as lesbian or gay or bisexual. And that ended up only being about 1,000 women. So I mentioned before that there's gold standard ways to measure this construct, right? To measure sexual orientation. And in more recent work with the same cohort with the Nurses' Health Study, we've been able to actually give them updated surveys that use this gold standard measure. And we're able to get a more nuanced approach to understanding sexual orientation. So in 2017, we asked them details not only about identities, but also about behaviors and attractions. By doing this, we realized that we had a meaningful number of people who had previously been classified as heterosexual that would be more appropriately classified as sexual minority women. So these are people who they maybe don't identify as bisexual or lesbian, maybe they identify as mostly heterosexual. Or maybe they say, well, I identify as heterosexual, but I have same-sex partners, or I'm attracted to people of the same gender. And these are people who are vulnerable to minority stress processes and may have a different kind of risk profile than completely heterosexual folks. So we use this more nuanced measure to examine disparities in cognitive decline. By using a more comprehensive measure, we were able to identify almost 8,000 sexual minority women in this sample. When we aggregated them together, they had 30% more symptoms of cognitive decline than their heterosexual peers. And this is the value of looking at this measure in this multidimensional way, is that when we disaggregated them into various sexual orientation subgroups, while there were increases across all groups, there was meaningfully different patterning, such that bisexual women and mostly heterosexual women, and this is a group that we couldn't identify in previous research, they had higher symptoms of cognitive decline than any other group, even though every group had elevated symptoms. And if we hadn't been able to use this more comprehensive measure, we wouldn't have been able to identify this group of people and show the extent of this patterning. And we would risk this bias towards the null by incorrectly classifying these groups as heterosexual. So I've shown you some of these barriers and some of the way we've been able to address them with survey data. But in future work, we're hoping to harness novel data structures to go even deeper. My team's proposed R01, which is currently under review at NICHD. We're proposing to use insurance claims data to try to address some of these problems. So we're specifically going to be using MarketScan, which is this large database encompassing multiple insurers, as well as Point 32 Health, which is a large insurance company that covers all of New England. Unlike survey data, we have a huge number of potential participants, which powers us to look at a wide variety of outcomes. In our first paper, which is currently under review, we identified over 500,000 sexual minority participants in MarketScan. But our approach to identifying sexual minority folks using claims data is by looking at the sex of their partner, which makes several assumptions. That they're on their partner's health insurance, and that people who are not in same-sex partnerships are heterosexual. And we know those things aren't true. Those are two major assumptions that are going to bias us towards the null. So one of the innovations that we're proposing in this grant is that to corroborate this approach, to understand how valid it is to use this measure of sexual orientation, this partnership measure, we have the opportunity to actually send out surveys to everybody enrolled in Point 32 health insurance and ask them their sexual orientation using this multidimensional measure, so we can actually see how good is it to use this other proxy approach. So of course, there's lots of epidemiologic considerations to using claims data, and I'm happy to discuss those, but we can save that for the Q&A if people have further questions. So I've walked you through some of this, kind of the major contributions to my work exposing hidden health disparities. And I've touched on some of these points already, but the takeaways for policy, practice, and intervention are that we need to enumerate populations to even know anything about them. You're not going to count if you're not counted. Disparities work is really descriptive, but it is essential to understanding which groups are the most vulnerable so that we can start to identify targets for prevention and intervention. And this really does matter for messaging. So we've really gotten the messaging wrong, particularly for alcohol in the past. About 10 years ago, CDC got a lot of flack for this extremely problematic campaign where they told women in their reproductive years not to drink at all because they were pre-pregnant. They got a lot of backlash for that. It was not very well received, but it was very well intended. A more nuanced approach could be actually looking at the groups of women who are increasing drinking and trying to meet them where they are. So a combination of workplace-based campaigns about the benefits of reduction, as well as efforts to push clinicians to actually screen women in the midlife because they're really not getting screened. And then outside of prevention and intervention efforts, there are policy and practice changes that result from this disparities work that do move the needle. So in the past year, the Centers for Medicaid and Medicare, for the first time ever, started asking people about sexual orientation and gender identity. And this is a major insurance practice change. This is going to allow us to target and ameliorate disparities. And this is only possible after years and years and years of survey research that has documented these disparities, called for more systematic data collection. And given that there's very limited information about healthy aging for LGBT folks, this is going to be an extremely important advancement for population health. And it's going to be critical for translating these findings into meaningful interventions. Okay. I'm going to pivot to another major component of my scholarship, and this is the use of novel measurement. I've used a variety of novel measurement techniques to better understand the nuances of health disparities, and I'm going to walk you through a couple of examples of them. So one of my areas of expertise is the use of latent measurement approaches. These are simple machine learning tools, and they can help us measure phenomena that can't be observed directly using characteristics that can be observed directly and reducing them into the construct of interest. They're empirically and they're theoretically informed. I'm not going to walk you through the nitty-gritty of these models, but I'm going to show you some examples of how they've been utilized so we can both better explain and understand health disparities as well as get at their structural causes. So I've shown you some examples of how social identities and social roles like labor force engagement and parenthood are relevant for health outcomes and for how they're patterned. But people can occupy multiple roles at once, and they can occupy them at different times in the life course. So for this example, we looked at women enrolled in a longitudinal cohort over many decades to see how they patterned these multiple roles throughout the life course, to what extent these patterns were shared, and how these patterns impacted mortality. We used a data reduction technique called social sequence analysis. And this allowed us to group people into unique life sequences based on the timing and distribution of these different roles. This technique allowed us to basically reduce decades worth of survey data into apples to apples comparisons of life sequencing. How are people patterning their lives? And this image is just showing representative sequences. What we found was that the social roles have additive effects on health, but that the timing and the sequence of these roles really matters for mortality. And I'm using a similar technique in some ongoing work examining trajectories of alcohol use across emerging adulthood. So here we're following people from ages 18 to 30 and examining common patterns of alcohol use using a technique called latent class analysis. What we are able to do is reduce 12 years worth of survey data from over 50,000 people into one of 7 common trajectories. So for example, some people exhibit, let's see, heavy drinking when they're younger, and then they transition to moderate drinking. some people abstain throughout this period. And what we're going to do is look at predictors of these common trajectories, as well as to what extent these trajectories are more or less predictive of future alcohol use disorder. This can tell us not only about which behaviors lead to highest risks, but also about the patterning and timing. Okay, so I've used latent modeling approaches to look at health disparities at the individual level, but the majority of my contribution to the scholarship has been at the structural level. I'm specifically interested in structural causes of disparities, such as area level policies, cultural attitudes, or systemic inequalities. Quantifying their impact has often required building new measures of structural exposures. So there are some specific considerations for conducting this research. And something I really value about doing this work is that we do have to think creatively to grapple with some of them. The first is that structural exposures need to be measured at the structural level. If we wanted to know whether a transgender woman in a state with civil rights protections had better mental health than a transgender woman in a state without these protections, it's not good enough to ask her what the law is. When we examine the health impact of a structural exposure, by asking an individual to appraise that exposure, we run into two different biases. One is reverse causation, that somebody who has worse health might appraise their environment as more hostile. The other is just misclassification. People don't always know what the law is. They just don't always know how to appraise their structural environment. And it doesn't matter. You can experience the effects of a law whether or not you know that it's the law. So structural exposures need to be measured at the structural level, and this can mean measuring law directly if we're looking at a specific policy, or it can mean aggregating individual level attitudes to an area level so we can get an average measure at the structural level of interest. The next thing to consider is identifying data sources that will provide structural exposures. For policy impacts, we often rely on policy watchdog organizations or data consortia that track changes in policies of interest, and they often make them available to researchers. It's a great resource. For attitudes or exposures related to climate, we can utilize national surveys that gauge people's opinions about the topics that we're interested in. And these are really good resources, but they're also really limited in their sample. So if I wanted to use the general social survey to understand if a specific place was more or less homophobic, it would require that there's enough people from that place that I can really get a reliable bead on what the climate is there. So if I want to know how many people opposed same-sex marriage in North Dakota in 2006, there's going to be spare survey data. And that can do things to reliability of the measure that can get very weird. So newer measures have been making use of publicly available resources that maybe weren't intended to be used as data, but we can use them to get a beat on attitudes. So these can include public data resources like Project Implicit, which I'm going to talk about in a couple of slides, as well as passively collected and geotagged social media data or data from other public repositories, which I'll talk about in future directions. So we also need to think critically about the samples we're using for assessing both the exposure and the outcome. In order to measure the impact of structural exposures, like I said, you need sufficient people, but you also need variation in that exposure. So you either need people from all over the area of interest or across time or both. And I talked about this in the previous slide, but this can be a real bottleneck. So this paper, we were creating a measure of structural transphobia. We just didn't have enough people in Alaska, Wyoming, Montana, or the Dakotas to get a full picture of the culture there. And we also didn't have enough survey residents for outcome data there, so they were just missing. The last point I'm going to talk about is content and timing, but I'm going to come back to that after talking about these other 3 points by giving you some details. And I'm going to start with a very straightforward example. This is a study where we showed that a structural exposure was a cause of a health disparity. This is so I can illustrate some of the concepts that I talked about in the previous slide. In a recent paper with my collaborators, both in sociology and in psychology, we examined how living in a state with more protective anti-discrimination policies that protect the rights of sexual minority folks, how that impacted birth outcomes for lesbian and bisexual women in Haines. What we found was this dose-response relationship between the risk of preterm birth among lesbian women. So as states became more protective, the risk went down. To do this, we needed a structural measure. So the actual number of discrimination policies, this was provided by a watchdog organization, as well as a sample with individual level outcome data. And they needed to live in different places. We needed a sample across the United States. Oh, there we go. I also wanted to just flag in this case that you can see the disparity closing as the policy environment got more equal. Okay, so that's the general framework, but sometimes the structural environment varies in ways that's not reflected in the laws and policies. We know that there's changes happening, but it's not really encoded in the language of policy. What's happening is more complex. So this is where novel measurement approaches can really help. You'll recall that some of the work I showed you earlier examining women's drinking showed these really different patterns based on socioeconomic and labor characteristics. And when I looked at these, I felt like I was staring at this big cultural change related to women's status overall. That we know areas where women have been socially excluded, like in the workforce, in higher education, these are starting to become more equitable, and gender norms around alcohol use have been getting less restrictive. And as this has been happening, women have more purchasing power. They can buy consumable items like alcohol. And these norms have also relaxed. So for my dissertation work, I wanted to examine to what extent changes in structural sexism were responsible for these increases in women's drinking. In order to build a measure of structural sexism, I used the American Community Survey and the current population surveys to identify indicators of historical exclusion for women. So this is places where there's been unequal representation of women, and that's political, socioeconomic indicators. And that allowed me to create a sexism score for every state in the US that varied from 1988 to 2016, so I could make this apples to apples comparison about the sexism environment depending on where and when people lived. I used a multi-level factor analysis to identify the most meaningful indicators and was able to effectively assign each state a score. Then I brought in longitudinal survey data that followed women over time living all over the United States. And I showed that women's alcohol consumption did vary based on state level sexism. And this association varied meaningfully by individual socioeconomic position. So in places with higher sexism, drinking did not vary by work status. But if women lived in places that were more gender equal, there were pronounced disparities in alcohol use by work status. I'm not going to go into great detail, but the take home point is that the structural sexism environment is one cause of these gender trends in drinking, and that it interacts with individual characteristics that influence women's drinking behavior. While the previous work looked at political and socioeconomic indicators of women's status, sexism, of course, also includes attitudes about women, and those vary from place to place. So I wanted to highlight some of the work we've been doing with this novel data structure project Implicit. We've used this for several papers to tap into attitudinal climate. So this is a non-traditional data source. It's from a consortia of researchers at Harvard that it's like a psychology project where people go online and they take these implicit association tests to see sort of what their biases are. And then to validate those tests, they're asked questions about their attitudes. So people log in, take these tests, and then report their attitudes. And we know where they live and we know what they think. And so we're then able to take these attitudes, average them to the geographic level of interest, so that could be the county or the state, and use data reduction techniques like factor analysis to be able to say, this is the average attitude based on these surveys in this place. And it's a lot more information than you get in a traditional survey. We can then link those scores to another data set with different people that has health outcomes at the individual level. And then we can see to what extent these attitudes matter for health. So one example where we did this, this is a series of papers I worked on with a collaborator at Boston College. We used a technique called geospatial meta-analysis. What we did was we took an existing meta-analysis of clinical trials. We figured out where those trials were conducted. We just tracked down the location. And we linked those study locations to our measure of sexism, which we created using Project Implicit. So in this study, this was about the efficacy of psychotherapy for kids. It was basically like, does psychotherapy work for kids? And we showed that when girls live in a place that's sexist, psychotherapy doesn't work as well. But the effectiveness of psychotherapy for boys is not sensitive to structural sexism. We've showed something similar with the same sample with anti-Black racism and Black youth, and we've done something very similar with structural transphobia as well. And so some implications of this work is that if you're a practitioner and you're treating a vulnerable kid in a hostile climate, you might want to think very deeply about your techniques, that the same techniques might not work across different structural environments. In other words, we might need to have different strategies to address individual psychotherapy needs in a more hostile environment. And this is actually really consistent with other findings from psychotherapy of LGBT kids when practitioners actually engage with the laws and policies on the ground. It's much more helpful than just using the traditional techniques that we use at the individual level. Okay, so another important consideration for measuring structural causes of disparities is to take into account the content and timing of these different structural exposures. So some of this I've done using very simple measurement approaches, and some has required some more complex approaches, and I'll take you through just a couple of examples. So this is a paper where we show the importance of timing and content. And this involved looking at bias-based litigation on homophobic bullying. So this one wasn't particularly fancy with regard to measurement or data reduction, but it does provide some insight into how content and timing can really make a difference. And these are exposures that are going to be very relevant for sort of what we're looking at for health outcome and what we can expect from an intervention. So in this paper, my close collaborator and I worked with 2 lawyers. They were civil rights lawyers. They wanted to know if ACLU cases about bias-based bullying made a difference. So if I'm at the ACLU and I bring forward a case saying that a school was discriminating against a student by not protecting them from homophobic bullying, does that actually reduce bullying in the school? And does it reduce bullying in the school's district? So to answer this question, we linked schools that had these ACLU cases to survey data that was collected at the school level for kids in California reporting homophobic bullying. So we looked at schools that had been subject to these lawsuits, as well as schools in the same district where the lawsuit arose, using this difference in differences design. What we found was that after the court case was filed, but before it was decided, you can see there's no difference in homophobic bullying. But that after the case was over, homophobic bullying dropped 16% in schools that were sued, and 12% in schools in that district. So a school that was subject to a lawsuit about homophobic bullying, after those cases resolved, did have a decrease in bullying. So the case worked. And this is a sizable decline that was really meaningful to our lawyer collaborators to bring back to their colleagues and say, this is really working. But it also wasn't enough to bring the case forward. We found this kind of slightly insidious finding. If the court case ruled against the ACLU, homophobic bullying increased. So it's not enough to bring the case forward. The ACLU had to win the cases in order to actually see a reduction in homophobic bullying. And we couldn't really have demonstrated this if we hadn't thought carefully about the different timing components of the case, as well as sort of what ends up actually happening. It was to do with both the intervention as well as which direction the intervention took. And I want to tell you about one more example where the timing and content of the structural exposure matters. In this study, I once again used a latent measurement approach to conceptualize the structural policy climate. We wanted to know if all policy climates were created equally. So in this paper, my collaborators and I created a measure of policy climate using a series of 11 policies and laws that were related to LGBT protections or a lack thereof. And we looked not just the number of discriminatory policies, but also their trajectory. So we were able to classify states as either consistently poor, so these are the orange states where, and this corresponds to this group, there was just no adoption of supportive policies. These green states that started off with supportive policies and just got better. And then these purple states where they started off really low but ended up high. So even though these purple states and these green states kind of ended up at the same places, they got there in very different ways. And we found that even if a state ended up having high policy support, where it started mattered. So we looked at HIV outcomes among gay men, and we found that the risk of HIV diagnosis and AIDS mortality was a lot lower in states that had consistently high policy support in this trajectory of the green states. In states that started off low, but got high, HIV risk and AIDS mortality was lower, but wasn't actually statistically different from these consistently poor policy support states. So in other words, the policies do matter, but the timing and the trajectory of policy support is also really important for these health outcomes. So in my forthcoming research, I'm going to extend this work regarding latent measurement approaches to trajectories of structural exposures. I'm specifically interested in the impact of structural homophobia over the life course, as well as over time. So this is a major goal of my K award, which was recently funded by the NIAAA. One of the major barriers to looking at structural homophobia over the life course is that we actually really don't have very good measures to go past earlier than the 1990s. So if I wanted to look at exposure to structural homophobia in a person in their 60s today, I wouldn't have a lot of variation prior to 1999 in laws and policies that they would have been exposed to. So I wouldn't really know what it was like when they were growing up. And also there weren't surveys asking questions related to attitudes. There was just no information. So what I propose is to create a brand new measure using natural language processing. And this will be using publicly available texts of newspaper sources that date back to the 1940s using the Library of Congress and Google News. This is a major training aim of my grant, the natural language processing component. But we can use these machine learning techniques to understand how sexual minority folks were represented, if they were represented more positively or negatively. And we can use the geotagged information about where this news was coming from to basically say, this is what the climate was like in this particular area at this time period to make this apples to apples comparison using these sort of non-traditional data. And once I built this new measure of exposure to structural homophobia, I'm going to see how it influences alcohol use for LGBT women across the life course, as well as alcohol use of their children. So to do this, I'm using two linked intergenerational cohorts. This is the Nurses' Health Study and the Growing Up Today study. And I can look at structural homophobia at different points in the life course and see how it affects these trajectories of alcohol use for sexual minority women. And then how their personal exposure to this toxic structural environment or to a supportive structural environment influences not only their alcohol use, but the alcohol use of their children. And this is going to be the first study to examine intergenerational impact of structural homophobia across development. One of the really important components of these aims is looking at individual level moderators and mediators. And that's because even though we obviously can't interrupt the structural process that was happening across the life course and across development, we do want to understand what are the processes that are buffering or ameliorating these effects. Let's see. There we go. Oh, I think I went backwards. There we go. Okay. So anyway, I've walked you through some of these major components of my contributions to using novel measurement to identify disparities and their causes. And much of this work is, of course, directly is designed to inform policy. It's often by testing the impact of specific policies, by examining the kind of impact of structural environments, as well as specific policies that are on the ground. And this cross-level work that I've discussed where individual level characteristics are interacting with the structural environment, they can help us identify places for potential interventions that can limit the effects, the adverse effects of these hostile climates. Okay, I'd like to talk about some ongoing and forthcoming work that directly tests the effects of specific policies and how I envision continuing to build a program of research with an eye towards intervention and translation. Since the beginning of 2024, over 500 discriminatory LGBT bills have been introduced in state legislatures. This is overwhelmingly more than in recent years. So I collaborated closely with my mentors at Harvard and some collaborators at BU to submit an R61 to collect new data to investigate the impact of some of these newer laws. We're proposing to use a mixed methods approach to examine new laws that are being passed now. We're going to look at several types of laws that are LGBT targeted policies. Some of them are religious exemption laws. These religious exemption laws say that businesses or healthcare providers can deny services to LGBT people based on their religious beliefs. We're also interested in looking at two different types of laws that influence LGBT youth. So those are the Don't Say Gay bills, as well as these trans health bills that don't allow providers to provide gender affirming care. We're proposing to collect new data from the Healthy Minds study to quantify associations between these policies, experiences of discrimination and mental health among young adult college students in the United States. And then we'll do qualitative recruitment. We'll do recruitment and qualitative interviews with 120 of these participants from Healthy Minds to really try to understand what are the mechanisms and mediators of these laws, what's the experience of being in a place with these laws. We'll then examine these relationships using quasi-experimental methods in a nationally representative sample of the BRFSS and examine individual level mediators and moderators that could potentially buffer the effects and be targets for intervention and prevention. And while we're waiting to hear back from that particular, on that particular project to get it started, I did want to also highlight some other ongoing policy relevant work that's very close to my heart. So this is deeply related to many of the other questions I've explored today, and this is what's brought me really into this research. So I've returned to work that initially motivated my research journey, and that's reproductive rights policy. Now that I have a toolkit available to critically analyze policies and laws related to reproductive climate and to understand kind of their impact on population health, over the past couple of years, I've been involved in several projects related to abortion laws and health. In the first paper, this came out earlier this spring, we examined a restrictive abortion climate using an aggregated measure of state laws and policies. And we used mediation analysis to show that living in a state with a more restrictive abortion climate led to an increased probability in carrying an unintended pregnancy. And that led to increases in stress and depression during the pregnancy. In the subsequent project that I'm actively working on with some collaborators at Harvard and at UMass, we're looking at abortion policy using this intergenerational lens. In this study, we're curious about if abortion policy climate at the time of pregnancy impacts the subsequent health of the children of those pregnancies. So this is very preliminary, but we're using intergenerational data sets to look at whether the abortion policy climate at the time of pregnancy leads to any changes in the subsequent children of those pregnancies in risk of depression, trauma symptoms, or adverse childhood experiences. And a major priority of this work is considering maternal and child moderators to understand if there are buffering processes that we could target for screening and prevention efforts. I'm also interested in using alternative data structures beyond survey data to look at some of these more policy-related questions related to abortion climate. So this is ongoing work with collaborators here at Columbia, as well as a team of computer scientists at Stanford. We are examining how the abortion policy landscape since Roe versus Wade fell, if it's impacted the kind of health information that people are getting exposed to. So in this project, we're examining whether people who live in states that have passed abortion bans are getting more advertisements for anti-choice crisis pregnancy centers. And we're doing this using geotag data from Google search locations. One of the things I wanted to mention about this abortion policy research is that I do want it to make a difference. And so I am trying to forge partnerships with stakeholders, and I've been in conversations with people at the Guttmacher Institute to say, what would be helpful for us to show? What can we show from a data perspective and from an epidemiologic perspective that will actually move the needle for advocates to be able to bring that to stakeholders and say, this is what matters. And so this is all very preliminary, but we want to make sure that we're combining our powers to look at relationships and to find things that policymakers and stakeholders will take seriously. So looking forward, it matters to me to continue advancing work related to policies that are dangerous to population health. I didn't go into epidemiology because I only cared about one thing. And so I'm interested in continuing to use this skill set to examine questions related to policies involving other civil protections. Columbia Epi is home to state-of-the-art centers looking at substance use, gun violence policies, and those are extremely important for population health. My work examining intergenerational impact of structural social exposures is also highly outlined with the new community center at Mailman. And I'm excited to continue extending this work in a place where there is so much support and so much collaboration and so many resources for these shared priorities. I also didn't go to medical school for no reason. It matters to me to be thinking translationally, and I want to continue advancing work utilizing patient data and claims data. And I think there are a lot of avenues for systems and patient level change by collaborating across the institutions here. I was lucky to receive my medical training here, so I have a general sense of the hospital systems, how people get into these systems. And I look forward to using this experience and my clinical lens to forge relationships across schools and to work with other scholars at Columbia. And a lot of them are doing really similar work in institutions that we have a lot of opportunities to partner with. One example is Chosen, which partners, it's a Center for Healing Opioid and Other Substance Use Disorders, partners very closely with the Psych Institute, with the Irving Institute. And the Dalio Center is a Center for Health Justice that is working right at NYP to try to improve patient outcomes for patients who come into the system. And while we're working to dismantle these larger systematic structural sources of disparities, a really important avenue for future disparities work is identifying these downstream mediators and mechanisms that we can actually use to interrupt the impact of these toxic policies and these toxic structural environments. The example that I use is that we can't control the weather, but we can bring an umbrella, and we need to find ways to do that while we're doing structural research. This is not a policy or an intervention, but teaching students is an extremely important component of thinking translationally and making this research translational. I was lucky as a doctoral student here to get a lot of experience teaching master's, doctorals, and master's students, doctoral students, and medical students. Bless you. Mentoring is something that I take very seriously, and it's been a core component of my postdoctoral work, where mentorship is an important part of kind of whole department. Lots of opportunities to mentor analysts, master's students, doctoral students, and fellows, using evidence-based techniques and mentorship tools in both formal and informal settings, and that's something that I really value about the culture here. I think one of the things that's important to my teaching philosophy and my mentorship philosophy is that not everybody who goes into this field is necessarily going to become a 100% scholar or researcher. They're going to go out and become public health practitioners. And we need to make sure that we are equipping people with rigorous evidence-based tools to go out and do this work at a very high standard. And I know that's a very strong priority for this department to make sure we are teaching methods in a way that when these people go out into the world, it's reflected in their work. So, all right, I'm right at time to summarize this component of my mission statement. Looking forward to my career, I hope I can continue to utilize these newer methods in ways that can speak directly to changing policy environments and to inform intervention and translation. This is going to require building partnerships, working across disciplines, making sure that the work I'm doing is speaking to the stakeholders who are involved. And of course, a critical component of advancing this work includes teaching and training the next generation of future scholars, but also practitioners and public health professionals. Thank you all so much for your time. Thank you for coming to my talk. It's been really great to be here and meet with all of you, and thank you for your time and attention. This work has required a lot of multidisciplinary collaboration. I have a lot of brilliant collaborators, and I want to thank them all. Some of them are here in this room. This work is very exciting, but it's also very humbling, and so this has required a lot of group efforts. And I want to acknowledge the support of my many funders. With their support, I've been able to continue advancing this research in exciting new directions. And I have left some time. Yes, I have left some time for questions. Thank you all so much for attending. I really appreciate it. Hello. All right. Do you have any questions? Yes, Lisa.
Thank you. That was a tour de force and really interesting. I just have a specific question, actually. I'm interested in what mediators you're examining as part of your K.
Yeah. So for the K award, one of the things that's really great about, so I'm using the nurses health study and the growing up today study, and it's such a resource. We have a lot of information about the growing up today study youth from basically ages 9 to like 35. And that includes surveys that they filled out as well as these parent surveys. So we have information about the dynamics in the household, as well as their developmental exposure. So a lot of the mediators that I'm interested in for the intergenerational component are about what's happening in the home. What kind of care are they getting? What's the parenting style like? And these are things that are actually fairly intervenable and that people are amenable to getting information about. It's a little bit harder with the life course structural exposure for sexual minority women component with the newspaper data, because we just don't really have a lot of that available yet. And that is something that is an extremely interesting and important avenue that I've been kind of thinking about for future RO1s. But for the intergenerational piece, I'm very much thinking about what's going on in the home, what's going on at school, what's going on in early life, as well as, again, we follow these people into adulthood. So like, you know, things like, are they completing their education? Are they going to college? Things that we can really track throughout development. Carly and then Carrie?
Me? Okay. Just quickly, I really enjoyed it. I love the policy angle of this and the fact that you're investigating differences that are going to make a difference, right? So that's really, really important. I had a question though about, because these data are coming up, project
Project implicit, yeah.
Right. And the way the data are collected by the psychologists at Harvard, the sampling structure raises questions. It's very non-random, yet the
Yes.
data are being used to represent states. I'm wondering if you could just speak on
Yeah,
it.
no, it's a great question. This is something we've thought a lot about, is should we do any kind of like funky weighting? So when somebody goes and takes a project implicit survey, here's the way they normally get into the system, is that somebody in the psychology 101 class, their freshman year, has said, you need to learn how to take one of these tests. This is a famous test we do. You need to learn about it. Why don't you go take it? And so people log into the system, they take the implicit association test, and then they give a bunch of demographic information, and then they give attitudinal information that's used to validate the IAT. And there's been a couple of things that we've done. One is, once we've averaged this information and said, here's the average attitude, we've also compared it to other known measures. There are some pretty good measures of racism. There's not as many good measures of sexism, but there are some pretty good measures of racism, and we've just done kind of a back of the envelope check. Do they correlate? Are they strongly related? And the answer is yes, they're very strongly related. So it's surprising that such a non-random sampling scheme would actually be able to give us a pretty high correlation. But if you look at more probabilistic surveys like General Social Survey, you actually see that once we have, I don't want to tell you that once we have enough people, we get at the real attitudes, but once we actually do have people representing their attitudes correctly and it corresponds to national surveys. The other thing that we've considered doing, but the correlations have been so good with other national surveys that we mostly haven't, is because we have information about these people's demographics, is using demographic weighting to then say, what if we could approximate the composition of the state using sort of like using weights that would correspond to like the makeup of the American Community Survey, that kind of thing. I've been surprised by how reliable this method is, because it does seem like it's a very non-random sample. It's mostly psychology students who are being told to take this test for credit for a class. But it's such a large data repository that has so many opinions that we are able to aggregate and find really meaningful differences that do correspond to other known measures. But it's a very good question. Mary, do you have something?
I was gonna ask you a question about your JAMA paper.
Oh, sure.
Showing increased rates of mortality, and I was wondering whether you and the research team are at all concerned about people weaponizing those findings,
Yeah, I am.
those findings around,
Yeah.
people of a certain
Yeah.
risk group have poor health are inherently
Yep.
worse. And
Yeah,
there's a lot of anti-LGBT
Yeah.
sentiment in the air, so, what are your thoughts on people using your research for purposes you don't intend them to do?
yeah, that's a great question, and this is something we were actively worried about. And this is something that even with this paper, which came out last month, has already started happening. There was a blog, there was like a far right blog saying, see, 8 people were dying earlier, and I read it and I was like, but in this particular instance, so when we know that, a couple of things, it's really important to get the messaging right, and that includes communicating the research to the public in a way that is, as much as we can, trying to communicate why things are happening the way that they are. And so this was a paper where we went on a very big press campaign, actually. We did a lot of work on the front end with how are we going to message this, making sure that we're writing it in a language that's digestible to a reader, but also making sure that we're putting out a press release saying that this is not because being gay kills, this is because discrimination kills. And that in every time that we've had an interview, we've had any kind of messaging about this paper, we're saying, we're not trying to understand the processes, we know the processes. This is well documented. The big finding is the mortality finding, but we've known forever that what's causing this, and what's causing this is discrimination, and that's leading to these intermediary health effects that are ultimately culminated in mortality. But this is an ongoing problem, and this is one of the reasons that I think it's important to always be thinking about this disparities research in relationship to the more structural research, and to have those go hand in hand, showing that yes, there's this disparity, and look, you can see it attenuate when the policies get better, and that these need to constantly be in communication. I don't think most disparities researchers aren't also interested in the more structural causes, but they need to be informing each other. And we see this all the time especially with LGBT youth suicide. I mean, this is something that I've seen in the media a lot, is that there's a lot of misinformation about people saying, and I think it's weaponizing, that, you know, I wouldn't want my child to be gay because then he'll die sooner. And it's like, that's not the problem. The problem is discrimination. The problem is that the world is unjust and we need to create better systems and promote information and pull on these levers to try to improve people's lives. Not that it's, you know, dangerous to be gay, but it's not a satisfying answer. I mean, it is something we worried about. Any other, oh, that's Sharon.
Hi, thanks so much. It's like so nice to see like this totality. I always am interested in the policy, you know, the policy study of substructural things, and then the interventions that are proposed. And the interventions, you know, like things like screening or, you know, making filtration are the downstream ones, which Rose, you know, showed us like paradoxical because the structural things have the least effect. Once you get down to that level, they almost, you know, they have tiny effects for any individual. And in fact, particular screening may not be effective or not be needed to catch the thing. So I'm wondering, like, is that because then to really get at curing the structural thing or thing is to hand it off to somebody else? And so we have this impetus that we want our work to have meaning and policy relevance. But then it's not really for the relevance of what it really does, which is speaks to prevention.
Right.
Because that's not in our wheelhouse.
Right, moving it from that level to the.
Do you know what I mean?
lower level.
So I always like wonder that this paradoxical thing with our urgency to want to make policy differences rather than to make a difference in a policy.
Right, I let me make sure that I'm speaking to your question, but I think. Yeah, there is this kind of like tango of saying, we're doing policy research and then we're making this this individual level leap. And that we also don't know that that's exactly translatable, but we're not totally sure we can do anything about the policy. And are we just handing it off to suggest to somebody else that they need to pull on that lever? And I think that there isn't actually a lot of multi-level work looking at interactions between policy and individual level interventions. This is something that people want to do, but often it's sort of beyond the scope of one project or another. So I don't know that we necessarily have a good handle on to what extent. I mean, this is one of the things that was really exciting about that psychotherapy study, because it's individual level psychotherapy in a structural level environment. And realizing that it just might not work the same was actually a pretty big finding, because in the room with the therapist, it's not like people are really engaging with the structural level environment. But I do think that we actually really don't know to what effect, to what extent we're really able to intervene at this intermediary level and how powerful that will be. I will say that the structural level really matters, but it is still pretty distal. So this is something I'm actively working on a meta-analysis with some colleagues looking at just sort of the global impact of structural stigma on LGBT health. And the partial correlation coefficient is like 0.05. It's like, it makes 5% difference in health, which is an odds ratio of like 1.2, which is a big odds ratio, but it's because there's so many things along the pathway that matter more. So to your point that, yeah, there's this population level thinking, there's these structural drivers, but you know.
I'm just saying, those make a huge difference up here.
Exactly.
But when you get to the people who already are, you know, whatever, down here, who have depression and need to be identified or whatever, that's already been, to use Nancy Krieger's terminology, embodied, right?
Right.
And so
They're already walking into the office with all of, like, they're bringing all of this into the office.
all of that discrimination has already been embodied.
To even get them into the room. Like, and so I think that this is also very much an open question. Like there's not, in the neighborhood space, I think there's a lot of cross-level policy work, and the sort of like laws and policy space, I think it's still emerging. And it is a question of to what extent that should happen in the doctor's office versus in some other more just like how individual, how interpersonal should these interventions be? Like, is there another level in the process? I think about not necessarily structural, but also institutional level levers. Like, what about the role of big companies? What about the role of like a workplace or a school or even a city? Because often we can't really change what's happening at the state level, but we can we can think about what's happening at another large level that's a little bit more proximal. But I hear your frustration.
Well, no, it's also your work as advocacy, saying what do you policy folks need us to
Yeah, what can we show
make an
you?
argument would be a way that.
I went to a really helpful panel at APHA where some people from Guttmacher Institute were like, here's what we would like to see. So if you can show us this would be very helpful for us. And the things that we sometimes think matter when we're out here doing this research are just not the things that are moving the needle. And we need to be in those conversations because we can't do everything. We can't do everything at once. I think a lot of us go into public health because we do want to do everything at once. But there are people having conversations in the State House, and unless we talk to them, we're not going to know what's going to move the needle.
Well, we're past time.
Sorry.
Thank you.
Stop the share and log off the Zoom. And Gerald, thank you for helping me get the room.
No, no.